it's okay with everybody. We have quorum and I will call, let's see, I'll wait till we're recording. Are we recording yet? Hang on. I don't see the little red button. Does someone else see that we're recording and I'm just missing it?
We are.
We are? Okay, fine. Then I can, in fact, thank you, Melissa. All right, we'll go back to that. Go back to your screen share, I think, of calling the meeting to order. Oh, and I see Brian there too, to welcome. Okay, so I am going to call the regular board meeting for the Renfrew County and District Health Unit to order. It being Tuesday, March the 25th at 10:02 a.m. I will start with our land acknowledgement to begin by acknowledging that the Renfrew County and District Health Unit is located on the unceded territory of the Algonquin Anishinaabe people. We honor the land and peoples of the Algonquin Anishinaabe whose ancestors have lived on this territory since time immemorial and whose culture and presence have nurtured and continue to nurture this land. We honor all First Nations, Inuit, and Métis peoples, their elders, their ancestors, their valuable past and present contributions to this land. Miigwech. Now I will ask for a mover and a seconder to approve the agenda. Oh, hi, Peter. Thank you. You're here. Jennifer, seconded by Peter. All in favor? That's carried. I saw you too, Mike. You guys were tied. Thank you. There are no delegations. Are there any declarations of conflict of interest today? Seeing none, I will move to the next agenda item, which is the approval of the minutes of the regular board meeting of the Board of Health for February 25th, 2025. Do I have a mover and a seconder? Jim, seconded by Carolyn. Thank you. All in favor? Those minutes are carried. Thank you. That moves us into our business, or there is no business arising on this agenda. So we move into our staff reports and call up our medical officer of health, Jason. Thank you. An awesome report, by the way. Before you start, I shouldn't try to jump in ahead of you. I just want to say that I really appreciated the depth and comprehension of the report and the many issues that you folks are managing and carrying forward. Thank you.
Thanks, Joanne. I appreciate that. So good morning, everyone. I will start us off with a few relatively quick updates from our Healthy Environments programming. So first here, just in our emergency management program, we are monitoring the spring freshet, and we attended the initial engagement meeting that's multi-sectoral with a number of different partners that you can see there in the report. And we do this every year just to see with the yearly snow and ice melt how things are progressing, monitoring the situation and any public health and safety matters that we, may have to work together on and potential emergency situations. So alongside this, we've also updated the flooding resources on our website. And as of the current status, Pembroke District has issued a watershed condition statement, which is sort of the lowest level of warning that they can issue. Flooding isn't expected at this time, but just that the water could be, a little more could be dangerous for boaters and swimmers and that sort of thing. So again, just monitoring with this group at this point. The other update I wanted to give you in Healthy Environments was a recreational water program. So our public health inspectors have been focusing a lot on this. Every quarter, so 4 times a year, we do inspect about 20 pools and spas across our area, Renfrew County and District. And so given that we're already coming to the end of the first quarter of 2025, we're making sure that we have those complete. And then lastly, for Healthy Environments in our food safety program, as always, we are offering a food handler certification course, and we offer that free of charge to the community. This is important because, in high-risk food premises, it's required in Ontario to have at least one certified food handler on site while open. And so far in 2025, we've offered 2 courses, and we've certified 68 people. So the next area I want to talk to you about, which is been a major focus this weekend for the last month around the Immunization of School Pupils Act, which we're required to enforce. So you'll probably recall as of February 28th, the number of students, or sorry, I didn't actually get to provide this update the last time, but just by the end of February, for your awareness, we were able to decrease the number of students that were not meeting the Immunization of School Pupils Act requirements by 479. So that's about 41%. And as you will be aware, as of February 24th, we did have to issue 360 second notices and suspension orders to students that were born in 2007 and 2017 who were not meeting their Immunization of School Pupils Act immunization requirements. As of March 18th, those had decreased to 235. And as of the end of last week, it was down to 177. So it has been coming down. And again, those orders for suspension will only be in effect if there's not an immunization or a valid exemption on file before tomorrow. So we are seeing a lot of last minute demand as we're coming up to that date. And basically our staff are continue to work very closely with schools, families, and healthcare providers to give them all the resources that they need so that they can meet the requirements under the Immunization of School Pupils Act. We're offering community-based clinics across Renfrew County and District that you can come as a walk-in or you can book an appointment. And people can also always be vaccinated through their healthcare provider. But just a reminder for everyone that that still has to be reported to us in one way or another. And so ICON is probably the easiest for most people electronic means of doing that. Next update is around our measles preparedness and response. And we talked about this, I believe, a bit at the last board meeting, and I'm sure you've also been, seeing some of the updates as it's been covered a lot in the news. But we have been across Ontario experiencing a really large measles outbreak, the largest in decades. As of March 12th, you can see on the report here, we had 350 cases. There's since been another update on March 20th, and as of that time, there were 470 cases associated with the outbreak, so it's still fairly active. Most of them have been in southwestern Ontario, sort of south of Hamilton and further southwest of that. About 96% of the infections, or over 96%, have been in people who are unimmunized or we don't have a known immunization status. Still at this time, we have not had any local cases in Renfrew County and District. And just to put in perspective how unusual the current situation is, our last case was actually reported in 1991, so it's been a long time. We have had some cases in neighboring regions, including North Bay and the Southeast Health Unit. So watching this very closely. And some of the things that we've been doing, we've been trying to promote the awareness of immunization as well as measles symptoms. And we issued a media release to that effect basically earlier this month. We also have been communicating with our healthcare providers and local hospitals regularly around measles and doing some direct nurse outreach to some under-immunized communities to offer information and immunization throughout Renfrew County and District. Just to have an idea of what our vaccination coverage rate is in terms of our school-aged children, we are higher than the provincial average, and we have almost 92% coverage for the measles, mumps, rubella vaccine. Having those 2 doses, which is what's on the routine schedule, is about 97% to preventing infection. So for anyone in particular born 1970 or later, I'd strongly urge them to check their vaccination status and to have 2 doses of MMR. They can get those vaccines through their healthcare provider or through the health unit, whatever works best for them, and in particular children and youth in that cohort. And so we have in the report here some ways to get more information either through our website or you can always just call our immunization line to ask. And then we've also been, if we do have a case, then we will be doing case and contact management, and which can be quite challenging with measles as it's airborne and one of the most infectious contagious infectious diseases that we know. For example, if a case of measles enters an airspace, anyone who enters that airspace 2 hours afterwards is considered a contact. So there can be quite extensive contact follow-up, and we're reviewing all of our procedures and policies and training that we have with staff to ensure that we're ready should we start to have some cases. And next thing I wanted to update you on is, the board passed a motion in January to support cross coverage with medical officers of health at neighboring health units for, temporary short-term absences like vacations. So I just wanted to let you know that that's already been successfully used and, with, in particular with North Bay Parry Sound. And so they've provided coverage for us, and I've also been able to provide coverage for them. And it just so happened that when I was covering for them, they had their first measles case, which was for them was the first since 1995. And so I was able to work with their excellent team and support that public health response to that, and take some of the lessons learned as well and apply that to our work here. So I'd say that this is off to a good start, and it's a great relationship that we're building there and with other public health units over time that I'm sure that we'll partner with. And my last update under the health protection area is just as usual on what's going on with the respiratory infections. Overall, it's a fairly positive picture. When one of our major indicators, our test percent positivity, has been showing that COVID and RSV are at lower moderate levels for the last 7 weeks, and they've been declining. Flu activity was higher, but it seems like it's peaked in early February and has been coming down since then. Um, Hospital bed occupancy had been at very high levels for quite a while for respiratory illnesses, but after you know being at that level for 19 weeks, it's since come down to moderate levels at the end of February. And we are still seeing very high levels of respiratory illness emergency department visits, but those have been slowly declining over last couple of months as well. So looking like a positive picture. And in terms of COVID hospitalizations in particular, if we look at the overall provincial picture, as of the last week that was reported, we had the lowest number of hospitalizations for COVID since July of 2021. So it looks like a positive picture there, and I hope to see that trend continue. For our health promotion programming, I'll just give a very short update here on the Renfrew County District Drug Strategy because we have Brian Brohard on the line, who's our coordinator of healthy schools and communities, and he'll be giving a more fulsome update on the state of the strategy and the draft recommendations that have been put forward. But just so you know, we did have our final report at our last meeting, community safety pillar, and you'll hear more about those priorities shortly. We also had our community engagement survey close, and as of the end of that, 180 people had responded, so we're happy to have that. And there'll be a summary of those responses included in the report. And we did circulate the full draft strategy to the steering committee at the end of last week, and shortly from Brian, you'll hear more about that. And following the approval, our plan is in the first week of April to release the report publicly. In terms of a couple of substance use indicators that we always monitor, as of March 6th, there were 3 suspect drug-related deaths so far this year, Renfrew County and District, and that's unchanged as of right now. There's also there have been 7 emergency department visits related to opioid overdoses so far this year, as of March 2nd. So, and the next update is on Stop on the Net. So this is a collaboration that we've engaged in with the Center for Addiction and Mental Health, or CAMH. And so they provided support for us to purchase ads on social media to promote their program Stop on the Net, which basically will mail to those who are eligible and sign up, will mail nicotine replacement therapy free of charge to individuals who sign up, and provide further support for them to help them quit smoking. So we promoted that for a 5-day period and had quite a bit of engagement. We had 560 clicks and almost 43,000 total views of those posts. Another exciting collaboration with our harm reduction nurse outreach team that also offers testing across Renfrew County District to our vulnerable populations or sexually transmitted and bloodborne infections. So we've partnered with the Ottawa Hospital and their regional hepatitis program, and on a biweekly basis, their hepatitis C nurse practitioner will be joining us. I'm really excited to have that and have that strength and connection there to get people into the care that they need with a hepatitis C specialist as soon as possible. I also just wanted to reflect on some of the educational initiatives that we're engaged in and training. And we have a really successful partnership with the Algonquin College waterfront campus to offer nursing student placements within their four-year Bachelor of Science in Nursing program. And so, for example, in the fall of 2024, we had a group of students assist in our harm reduction programming area to address community concerns around discarded sharps and drug paraphernalia, which was based on local feedback. And so students there created an educational video and an infographic covering the safe disposal steps and the places where you can dispose of those items. We also this winter and spring have a 10-week period where we're having two fourth-year consolidation students with us, and they've joined our harm reduction program as well as our vaccine preventable diseases programming, and they're getting to experience sort of all the different areas within both programs, and really excited to have them. I think it's a really mutually beneficial, relationship where students get a wide degree of exposure to public health nursing, and then I know our team also really enjoys getting to share their knowledge and have that partnership with the students. So really happy to see that continuing. And then my last update is on You're the Chef. And I know I've talked about this program before, but it's a train the trainer model where we engage with teachers, provide them with resources and training so that they can teach hands-on cooking skills, meal preparation, and nutrition aligned with the Canada Food Guide. And so we've launched three new programs in local schools for students in grades 5 to 8, and really excited to see this program continue to expand and to see the positive response to it. So that's it for the summary of my report, and happy to discuss anything or answer any questions.
Yes, Jennifer.
Thank you, Chair. Well, my first question is, what have you been doing all month, Jason?
Yeah, lots going on. Yeah.
I just wanted to say, and I know that Peter can back me up on the Frechette watershed. I know that our Bonnechere River management system has been working far better. And I know that, I'm not on the Ottawa, but having dealt with the floods on the Ottawa in 17 and 19 and the Bonnechere River in 17 and 19, we do have a much better handle on it. So I just wanted to add that sort of to your report as a supplementary.
Thank you, Jennifer.
You're doing a much better job.
That's great to hear.
Yay, team. I'm looking to see if there are any other hands up. Oh, yes, James.
Thank you, Chair, and just through to Jason, yes, thank you for an excellent report. I just had a question on the You're the Chef program. Is this more of technical presentation? I know it's very difficult sometimes to incorporate some of the practical skills into the classroom, but how is that program administered as far as giving the kids some hands-on experience, or is it mostly just through video presentations, etc.?
I think there is a fair amount of variability, and we try to work with the teachers at the schools to, match their needs. And that's why we try to find curriculum connections, across the breadth of lots of different areas. So some of it may be, in certain cases, a bit more high level, but I certainly think there are practical applications as well. And I'll just open it to Patty, our Director of Health Promotion, if you want to add anything.
Sure, I'm happy to be added to that. Just sort of zooming back a little bit, the key role that our community nutritionists would have is training the teachers. And it is a fairly fulsome program. And we were able to some time ago add some resources to it, which is the cooking materials, so that they have the tools. And in past times, there were certain pots of money that we sort of were able to reach, and school boards have been able to secure the food side of it. So there is a very active component of creating and using tools and making food. And something that we've seen the kids really happy about is we provide aprons that they wear in the production of food. So as noted in this report, we're happy to add new schools to the program. And something else just to add is, we evaluate this on an ongoing basis, and we really applaud the teachers who take the time to implement in the schools, because it seems to have really positive impact on the students.
Thanks, Patty.
Thank you for that. That's excellent, and so pleased to hear that the program is growing.
Mm-hmm. And I do see Troy and then Carolyn with their hands up. So Troy first.
First of all, thank you, Dr. Morgenstern, for the wonderful report. I just wanted to comment just in regards to the collaboration with the North Bay Parry Sound in regards to their measles outbreak. I think I just wanted to kind of, just reiterate, that coordination and allowing that learning to take place within River County District Health Unit, especially with their one outbreak. Hopefully we can remain, continue our streak of 34 years free in terms of measles at River County. But at least we have that valuable experience in terms of, the first inaugural case that we're working with. That wasn't in our county, or in our district, but it was just a wonderful news to hear that collaboration is working very well. My second question was in regards to you're the chef. Is there any consideration in terms of working with various different businesses, restaurants, and those kinds of things, just to bolster maybe some of the impact, and also, have more of a community-wide approach? Like, I'm sure that there's lots of restaurants that would love to donate some of their time to show the children in terms of how to create a healthy dish, how to eat healthy, how to, procure, fresh vegetables and those kinds of things, and making sure that, that we have those foundation pieces for our children. So just give it some consideration just in terms of maybe, and now that we're, going into where we have, our status in regards to charity status, I wonder if there's an opportunity there we can kind of get some donations to help, and maybe just a campaign associated with that would give us a little bit more publicity to provide us some more, I guess, opportunities, some more materials to provide, wider ongoing opportunities. So I just thought that would be a great idea.
Thanks, Troy, for those thoughtful comments. I see Patty came off her mic, so I'll hand it straight to Patty to see if you wanted to
Yeah, sure.
share your thoughts.
I have two thoughts, Troy, and thank you for that to put into our hat for thinking about in working with schools on procuring the food for the programs. And as a reminder, it's interesting that this program in our school system is targeting grades 5 to 8. We've actually, you reminded me, just very recently, we have worked with the Youth Wellness Hub, and which we know really does well for our, vulnerable 18 to 25 population, and done the training for You're the Chef and they're now implementing it in their wellness hub. Just as another note, but thank you very much for that connection with our local food sources, because it is something every year that we work with the school systems to make sure that they have the food to run the program. So thanks for that.
Right. And no, so I have, sorry, I didn't, are you, sorry, Patty, were you, yeah, okay. Carolyn and then Peter.
Thanks. My question's kind of along the same line with the you're the chef. I know Patty said that they train the teachers. I guess what I wanted to be, do the children themselves get hands-on training? That's what I'm wondering.
Yes, they do. Yeah, definitely. So they train the teacher on how to, go about teaching and provide them with resources, but then the teacher guides the students through the hands-on aspect.
Thank you.
And then Peter, and I think maybe after that, we'll move on to the next agenda item. Thanks, Peter. Come on up.
Thank you. And again, what a great report. Thank you very much. Two questions. One is the measles and whole inoculation question. I guess, are we going to spend more time educating around that? Because it seems that we've, the whole, I guess all of Canada and probably even most of the Western world suddenly is pushing back against it. And I recognize that it may seem like a hopeless endeavor sometimes. Is there a means of educating? Is it educating right at the hospital when children are born, or is it prior to that, part of the prenatal care? So I'm curious if we have a strategy, or if we give any thought to a strategy going forward. And then I have a second question.
Sure. So you're speaking of sort of a broad strategy around vaccine hesitancy.
Exactly.
Yeah. Unfortunately, it is something that we've seen increase somewhat, particularly since the pandemic. However, I will say that with some of these, routine childhood programs that have been established for a long time, it is less than, with some of our seasonal vaccinations. At least that's what we've generally observed. And I mean, I would say throughout the life course, kind of we engage on vaccination at different points. So when people are born, our Healthy Babies, Healthy Children team is engaging with families. And one of the things that they talk about is vaccinations. And we have our relatively new Let's Grow program, we're calling it, which is a partnership between our immunization nurses and our Healthy Babies, Healthy Children, Healthy Growth and Development nurses. And, to offer those clinics. And one of the key components of that is education around immunization. And so when we're doing that outreach at early in life, we engage in some education around that. And then really throughout the school year, right, under Immunization of School Pupils Act, we're required to monitor our immunization rates. And so we're always sending some education materials out. And again, just as a last resort, we are required as well to enforce the immunization status for vaccines like measles, through suspension orders, which again it's rare that we get to that level, and we never want to. But I mean, in particular with measles, we released our media release earlier this month. Around the importance of getting vaccinated, what that means, what the symptoms of measles are. We've updated our website. We've got a dedicated measles webpage, and there's also a banner that pops up right when you get onto our website that kind of directs people to that. So we've done some of those short-term things, with this particular crisis. And again, the other aspect of it, with some under-vaccinated communities that we know of, we are doing direct outreaches with nurses going out, actually going door to door, providing some information and offering immunization. So we've got a sort of multifaceted strategy, through those different avenues where we're trying to provide information and increase our vaccination uptake. But it's certainly something we could always, continue to improve. And it is a challenge because there is a lot of misinformation out there around vaccines.
And
so
this is where I always wonder, just to kind of jump in for a second, if there's anything that from the health unit's perspective that you feel that any of us could do from our vantage point, whether it's from, a municipal-led communication or any other efforts that you could think of. If there's anything that you could think of that we could do to augment the effectiveness of the messaging, then please, engage in and ask us to do that. And then the other thought that when I was listening, I was wondering, does the health unit know the number of homeschooled children? And is that a group that's less likely to be vaccinated? And then do you have inroads into that group? And I'll stop there. And I know, Peter, you had another question.
In general, we don't know we don't have immunization stats on the homeschool on kids that are homeschooled. The legislation under ISPA only applies to, it does apply to private schools and public schools, but it has to be a school environment. So no, we don't have a direct knowledge of that.
But that, if I may, Chair, can I just ask Jason, is that why you're doing the immunization Jehovah Witness program, like to capture those kids that are homeschooled but might be going to, say, a library twice a week for their homeschool program? That would be my concern, is that those kids are still, even if they're homeschooled, they're not sequestered at home. Our library here has a very robust homeschool program.
Yeah, we are doing outreach to the community that's been sort of most affected by the outbreak across Ontario. And that would be inclusive of if there are kids that are homeschooled, and we would certainly offer immunization. Definitely they're eligible for it. So we are doing outreach again to some of the most vulnerable in our community to infection. And so that's part of our strategy. And it wouldn't just be limited to those in a school setting, because we would offer it to the adults too. And I mean, our media release as well is not just targeted for school-age children, but really everyone, and making sure that they have immunization. The reason why we have the cutoff at 1970 is because generally speaking, people born before 1970, there was high levels of measles circulating then in Canada, and so they would have natural immunity.
Hey, and just this is sort of question 1A, and an observation. Is there any chance that for next year, given our donee status, now that we could arrange for a cash prize at the end of the year for immunization? When I vaccinate my baby, my name goes in for a draw, and at the end of the year, there's a $10,000 prize, because I think cash talks right now. And it's not going to change, so it might spur on a little more participation, but don't need an answer on that. But it's just not a thought, given our donee status and people needing money in our community. And so my second question, and it's a little more fulsome and there's no immediate answer as always, is with the success of the drug strategy, the youth wellness hub, and MESA and things like that, because there has been a steady drop, thankfully, in the number of people who are overdosing and then overdosing fatally. What's next? In terms of, is there something else we can do, to continue to drive those levels down, but at the same time, what's the next part of that I hate to use this word, problem chain, to make sure that it doesn't reoccur, or to help people who would consider it. And I know, part of the MESA Heart Hub application is housing and wraparound services and education, but is there something else that we can do at the health unit level, at the school level? I guess what's next? Is there another drug that we have to be worried about? Or, that's kind of the conversation.
Mm-hmm. Oh, thanks for that question and looking ahead. Yeah, so I'm sure we'll probably get into this a bit more when Brian gets into his presentation. But we will have our hands full just with the recommendations that are part of the strategy in its current form. So some of those we've made a lot of progress on, others are still much more forward looking. And so that's going to be one of the major roles of that steering committee moving forward, is to there's a number of indicators associated with each recommendation. And so to see how we're doing, and to adapt as we see what's working and what's not. And as you know, one of the pillars is prevention, and so Brian will give us a good update on that. And I do think prevention has to be a key focus. I think the success that the county and PRH and all those partners have had with the Heart Hub is going to go a long way in us making progress on the treatment recommendations. And I would say that the health unit has made a lot of progress on harm reduction. Again, still work to do, but I do think that prevention and will be a key focus moving forward. And in terms of other substances, that is the idea with the drug strategy committee. We don't want it to just be restricted to opioids. We thought it was essential that we focus on that at the beginning, given the acuity of the crisis there. But there's a lot of substance-related harms that go beyond that, and one that we might not often think of in the same vein, but is alcohol, right? So that might be something that we talk about.
Okay, good. Thank you very much.
Yeah.
Nice, for sure. And I know driving around on the back roads, I'm still so saddened to see that even as it was 20 years ago, you still see empty beer or whatever alcohol containers on the side of the road, which, as I say, always saddens me because people are drinking and driving. So on that note, sorry, not a cheerful note, let's call the question. How about a mover and a seconder for Jason's report? James moving, Troy seconding, all in favor? And that's carried. Thank you. Just sort of watching the time and hoping to get through the committee reports before Carolyn has to leave at 11:30. So that calls up Heather for our CEO report. Again, Heather, kind of the same comment. I noticed both your reports this month. I found them to be extremely informative and comprehensive. So thank you very much.
Great. Thank you, Joanne. Okay, so the good news, wrapping up the work on the qualified donee status, CRA has officially registered RCDHU as a qualified donee, and the effective date is December 19, 2024. The notification was issued in February, end of February, on the 26th. So as a result, RCDHU is actually listed on the public directory of qualified donees, as we've already checked and confirmed that. So moving forward, the work is going to be focusing on the potential cost savings opportunities that the status may offer and other areas that we're going to look into. So that's very good news for the organization. Partnership work. So the Renfrew Area Administrators Group has been busy in the first quarter. In January, we attended a meeting with the group discussing fiscal and resource challenges among the 7 partners. So there's actually 8, including us. And the current banking agreement will be expiring at the end of this year. So discussions are going to be held on this topic. And also, we'll be looking at other efficiency opportunities. So more meetings are coming with the finance leads in particular. And I think there's talk also with HR leads and IT leads and things of that nature. So all good work there. And RCDHU may in fact be hosting some of these meetings on site. So more to come on that work. Then in February, the senior management team did attend a full-day Truth and Reconciliation workshop, and it was organized by the 2 school boards alongside the community members from the Algonquins of Pikwakanagan First Nations. And it was a very excellent session, very intense. We collaborated with members of the other organizations and deepened our collective learning. The goal was to help advance commitment to truth and reconciliation in Renfrew County across the organizations, and more sessions are likely to follow on that good work. Risk management review, there was also a good report from the Ministry of Children, Community and Social Services, who are the funders of the Healthy Babies, Healthy Children program. They completed an extensive and detailed review of RCDHU's organizational risk levels. They worked with 2 members of SMT on this project, and there was various questionnaires, and then they had a meeting with, and they had to provide sample information that was requested and used for validation. So it was very thorough. Overall, we received a low risk organization score. and that means no further action plan is required. So that was very good news indeed. Okay, and as part of our good governance and management practices, part of the accountability framework of the Ontario Provincial Health Standards, item number 16 is to have client service standards and for the board to review, for the Board of Health to review these and have these updated. So these are now available on the contact page of our website. They've been reviewed by SMT and updated for everyone to review. These standards demonstrate our commitment to service excellence and communication, which are both goals from the RCDHU strategic plan. So our focus remains on continued service improvement to the community that we serve. And one little follow-up, the slides from the legal presentation from the Alpha Symposium were received. Melissa was successful in securing those, so thank you, Melissa. And they will be posted to the board portal. And that was requested from the last board meeting. So that is my report.
Awesome. Wow. I'm going to use Jennifer's line. What have you been doing for the past month? Busy report, lots going on. I really appreciate that. Any questions? James.
Yeah, thank you, Chair, and thank you, Heather, for that report, and also posting the slide deck from the Alpha presentation. I did want to just mention something. I don't know if we have access to the risk level results from other health units. I mean, my thought is basically that because we have given a low risk rating, would be nice if some of the funding from the province would be reflected in getting that kind of a result. Not sure if they would ever consider it, but just curious if we would have any way of knowing how we compare to other health units.
That's very very good question and interesting thought. I mean, we can look into that and find out if that information is shared, and we can get back to you next time on that for sure.
And Troy. Oh, there's Troy. Yeah.
My apologies.
There you go. You moved around on my screen for a minute. There you go. I see you now again.
Thank you, Heather, for your report. Very much appreciated. In terms of risk management review, I see that the dashboard was sent to the board chair for attestation signature. Do we have an attestation process for our CEO to provide assurance for the board that we're meeting all our legislative requirements? I'm just wondering if that's something that we have. I know it was sent to the board chair for attestation, but really the information is coming from, you know, our CEO and our MOH. So I just want to make sure that we have, you know, something like an attestation to say that we're meeting all our requirements, that we're aligned with the legislative requirements and legislative acts. So I'm just throwing that out there because we are looking at the procedural bylaw. And I thought this would be a good opportunity just to ask that question. So thank you.
Sure. So two things from that question then. That particular report, they specifically requested the chair to attest and sign that they had seen that report. And yes, as a practice, we do present confirmation of that. I believe that's usually in the May or the June meetings after we have the audit complete and we receive the certification from the different legislative bodies that we are all clear and up to date with payments of the different taxes, etc. So we do, that is shared in, like I say, the May or June, I'd have to look, but definitely something we could add as a more formal process.
We could talk about that at governance later, Troy. I remember from my previous role where I created a compliance report that I presented quarterly. It would say things like all the mandatory payments to Revenue Canada have been made and are up to date, and insurance policy is up to date, and just when I sign it, then my board would know that they've done their due diligence, and they have to trust that I'm telling the truth, and I have to be prepared to back up anything I say with proof. But then it was like a risk management tactic, if you will. But anyways, that's a good question. Thank you. If there's no other questions, and looking at the time, let's call for a motion to approve Heather's report. Do I have a mover? Carolyn, seconded by Jennifer. All in favor? And that is carried. Thank you. So that brings up Tom. And hey, Tom, I managed to keep at least 14 minutes for your.
It's Ethel.
Yeah. Oh, hi, Ethel. Hi.
My apologies for being late.
Oh, no.
I was delinquent this morning.
We knew that you were going to be late. Thank you so much for joining. Thank you. I'm glad you're here, especially for this next piece. Tom, let's call you up on the 2025 operational plan and risk mitigation strategies. Thank you.
Yes, thank you. Good morning. So yes, today I am presenting the 2025 corporate operational plan and risk mitigation strategies. And so the Renfrew County and District Health Unit's Risk Management Task Group held meetings between November 27th, 2024 to March 6th, 2025 to identify, assess, and address risks. Our work was guided by the Risk Management Strategy and Process Toolkit as we updated the RCDHU Risk Register. From the Risk Register, the highest scoring residual risk areas became the foundation of our 2025 Risk Management Plan. The 2025 Corporate Operational Plan was developed as the next step in managing risk for the organization, and it identifies 6 operational priorities that emerged from risks that had the highest residual risk scores on the risk register. The Corporate Operational Plan shows these 6 priorities, a highlight of the activities associated with each priority, and also how these priorities align back to the RCDHU strategic plan. The first priority is to effectively manage fixed costs rising in excess of funding increases. Related activities are those focused on cost efficiencies, reviews of alternative funding structures, including potential cost-saving opportunities from our qualified donee status. The second priority is to meet staffing requirements for programs and services. Activities include staffing practices to meet operational needs and activities focused on staff retention. The third priority is to mitigate impact of natural disasters with activities, plans, and communications focused on emergency preparedness. The fourth priority is to maintain vigilance and preparedness for emerging serious pathogens with the implementation of infectious disease activities, plans, and exercises focused on preparedness. The fifth priority is to respond to the increase in drug-related harms with partnerships, engagement, and activities focused on reduction of harms related to drug use. And the last priority is to ensure privacy in all health unit systems with assessment and strengthening of administrative and technological barriers to privacy breaches. The risk management plan also identifies risks that are referred to the Board of Health for action as they are classified as agency risks instead of operational. And these 2 risks have been sent for your consideration as well. Thank you very much.
Okay, so we'll just open the floor. Comments or questions? And I see that as you know, the risks that are kind of at the board level, financial and political, those are probably kind of constant risks for us, I suppose. I'm not seeing any questions or comments. Troy, yes, Troy, thank you.
Thank you for your report. I do agree with the priorities in terms of the corporate operational plan, and I see the agency risks remain the same as what we had last year, the financial risks and the political risks. Do we need to expand the agency risks in regards to maybe some of the impacts that maybe we would have in terms of mitigating, an outbreak? I'm just wondering if that's, I know it's on the corporation, the corporate operational plan, but is that not a huge risk for us in terms of, we're not getting, the vaccine uptakes, possible outbreak. I'm just wondering if we should add a third category under the agency risks, because I think that may impact our agency big time if, say, a measles outbreak where we have low or concerns in regards to other communicable diseases where we have low immunization uptake. So I'm just wondering if it has more of, because that would really make us pivot in regards to our direction. So in the event that we do have an outbreak, just a question.
It looks like Jason's going to answer that, I think.
Thank you, Jason.
No problem. Yeah, it's a great point. I think the way we're looking at it is we're trying to capture that under the emerging serious pathogen risk, and it is our highest ranked risk. So we totally agree. I think in terms of that, and so even this could be like another pandemic on the level of COVID or worse, or even a serious impact from a previously known pathogen like measles, right? So a lot of the preparedness work we're doing there would apply to those different situations. And I think in terms of the agency level versus operational level, they're not really mutually exclusive. Like certainly that would be something that we would communicate strongly with the board about. But it's just that in terms of our work on it, that it's at the operational level primarily in terms of preparing for that. But and I don't know, Heather, if you have anything else that you would add about that.
No, thank you, Jason. I think you've said it just about right. That that the focus of the work is at the operational level for that, and then again we would have plans in place for communicating with the board and any type of actions that are required at board level.
Thank you. I'm just wondering if there was a little bit more visibility required in regards to that risk. That's I think by putting it down in terms of our agency risk, it might be a little bit more visible for response and for action. That's all I thought. But that's fine. Thank you. I appreciate that.
Okay, great. And Peter, I think you were up next.
Thank you. Thank you. I like this. Can I make one suggestion? I'm a question. I'm a little confused about alternative funding structures such as merger feasibility. Is there any other mergers or potential mergers that are being considered and that we might not be aware of right now? And then secondly, is there an opportunity to after feasibility enter something like shared services? Because I think that was part of one of the preceding motions in 2019 or 2018 when we call it affectionately the Yakabuski memo, and it talked about reaching out to Ottawa and sharing training opportunities and staffing and such. So I'm wondering if we could add shared services in there and pursue that agenda that was laid out by a motion. So thank you. And just the first question about mergers, I was a little shocked to see that.
So I would probably defer that to our senior management team as well. Jason, you got your hand up there?
Sure. Yeah, there's no merger on the horizon that we're aware of, just to clearly answer that question. I think this is more looking back, and it's something that we did last year. We went through that exercise. And I agree the shared services is a priority. I believe it is in our longer list. This is just a few activity highlights, and so apologize that that's not represented there.
And I mean, in all fairness, Neil, I do know your hand is up, but on this specific issue, in all fairness, we are all aware, I'm sure, that just because we did not decide to voluntarily merge at the time we were offered that, we also kind of learned that other types of mergers were not being encouraged or funded. So it was really a health unit merger initiative, let's say, that the government was supporting, that we were not prepared to put our hands up and say, yeah, let's do it. In the back of my mind, though, I'm like waiting for the other shoe to drop. You know, we've had the election, they're back in, they're getting going. What will be the next message that we get about mergers? Will it be a forced? Will it be another voluntary opportunity? I don't think it's off the table in the sense of the future and potential considerations that we may be asked once again to examine. The Ottawa thing, Peter, absolutely was, we put every effort out into that, and that's like a done deal, no go. Well, at least it was a year ago. Ottawa was like, no, we're not talking to you about that. So our options have limited a little bit from maybe 2019. So it'll be interesting to see. And I do perceive that area of thought to be something that the board needs to perhaps spend extra time and effort considering in the coming year or two. I don't know how it's going to really shake out. I'll stop there. Those are just some of my thoughts that I've been thinking about this stuff in the background. Neil?
So if I might, we're going to try and catch the shoe before it drops. So,
well, ideally, the board will have that conversation and make some decisions and agreements about how to move that forward. So 100%, it's better if we're choosing our own destiny and delivering it with a nice bow to the government so that they say, ah, beautiful, we agree, fantastic, here's some money. I don't know if we missed that boat or not, but hopefully we can still benefit from opportunities in the future. Sorry, Neil, I called on you and then we didn't give you the floor, so let's do it now.
No, that's perfect, Chair. I wanted to step in on 2 points that Tom's raised in his presentation, and more comments than a question. The first one is just the partnership piece, and I've stressed this with you offline and Jason, that the partnership and the leadership that the health unit has put on the community drug strategy is a tremendous success. And I want to encourage that future operating plans and strategic plans include partnership as a key pillar of our effort going forward. And it's an area where we can try to mitigate risk in a lot of other areas in our community. So I really want to support partnerships. And the second one is communication. Communication is really important, especially in today's age where we're losing the traditional newspapers. There's only certain demographics that are on Facebook that are listening to CBC radio. We need to look at communications strategically, operationally, and how do we communicate with the next generation? I mean, it's only going to be another 10 or 15 years where TikTok will be the main area that everybody's grown up on and will be using as their source of information. Most 20-year-olds are getting all their news off in TikTok. Are we, as a health unit, or provincially, are we using TikTok as one of our forms of communication in the future? So those are just 2 comments to help shape future discussions that I wanted to make sure we have on the agenda. Thanks, Chair.
Awesome. I don't see any other hands. Can I call for a motion to accept the corporate operational plan and risk mitigation strategies? Ethel is moving, seconded by Neil. Thank you. All in favor? And that is carried. That's awesome. Thank you very much. Great discussion. I am totally confident that staff have taken away the discussion comments for future deliberation at the ops level, and we'll see more about that as it unfolds. And thank you all. We are perfectly on time to bring up Brian with the, well, no, we're a little bit over, but that's okay. Brian, you're on.
Great. Thank you, Madam Chair. Good morning, everyone. And you should be seeing my screen now for Renfrew County and District Drug Strategy update. Today, I'll be presenting you with an update on the strategy, which I know Dr. Morgenstern has been keeping you well informed of at these regular meetings. As you likely know, a steering committee of over 30 people from the nonprofit, private, and public sectors have been actively working together to address substance use harms in Renfrew County and District. The committee is truly embracing the call to action from Ontario's Chief Medical Officer of Health, who stated in his recent annual report that substance use cannot be addressed by the health sector alone. And I call for collaboration between communities, all levels of government, health and social services, the public health sector, the healthcare system, and all Ontario residents. The local steering committee, chaired by Dr. Morgenstern and Jama Watt, the strategic implementation lead for the Ottawa Valley Ontario Health Team, has truly taken this message to heart. We now are happy to report that we have a set of strategic priorities developed by our working groups and supported by the steering committee. There are 5 overarching priorities at the strategy level and 20 across the 4 pillars. From the outset of the strategy development, the steering committee and working groups have galvanized their response around this vision and mission. While there's initial focus on opioids, as Dr. Morgenstern mentioned, due to its acuity and harm in our communities, which at this time is primarily fentanyl and more potent fentanyl analogs. We know this contaminated supply will continue to change over time, and the steering committee is committed to adapting the strategy this year to include other substances, for example, alcohol, as noted earlier. We're using a very well-established and evidence-based model for the development of their community drug strategy that relies on the 4 pillars of prevention, treatment, harm reduction, and community safety. Prevention, we have defined as initiatives that are aimed at reducing risk factors for substance use harms across the lifespan, particularly those related to adverse childhood experiences, social determinants of health, and social inequity, all while increasing protective factors that promote child and youth development, family well-being, and community connection. Treatment is to focus on accessible and effective treatment options for those struggling with addiction and substance use disorders. Harm reduction is programs that mitigate the negative health and social impacts that are associated with drug use. And finally, community safety are efforts to reduce drug-related crime and the community harms while supporting individuals in need of treatment and recovery services. And related to each pillar, there has been working groups established, which include community leaders, service providers, and people with lived and living experience who are contributing to the work. Each pillar working group began by providing a situational assessment to the steering committee, then identified strategic priorities. And on an ongoing basis, these working groups will be tasked with implementation and the monitoring of the indicators associated with their priorities. The 5 overarching priorities for the drug strategy were developed as the working groups presented their reports, because it was quickly acknowledged that there was repetition and some duplication between what many of the working groups wanted to achieve. And those would be to enhance access to services in the user's language of choice, continuing to reduce stigma, providing culturally safe and appropriate services for Indigenous people and people from other equity deserving groups, and ensure the coordination and communication across the strategy, and to conduct rigorous and ongoing surveillance and monitoring to inform future action. Now, under the prevention pillar, there are 5 priorities. As noted earlier, many focus on adverse childhood events and the social determinants of health and increasing community connection, all while ensuring that there's early mental health care and support of children and youth is a key focus. And we're extremely privileged to have the Phoenix Center staff and OVOHT staff chair this working group, where they identified the priority 1 would be to improve early and equitable access to screening, assessment, and diagnosis and pathways to care. So this recognizes that child and youth mental health and substance use health are closely related, and that a lack of diagnosis through formal challenges can be a barrier to receiving the needed services. will require a review by partners to improve using an equity lens the pathways to screening and assessment in Renfrew County and District. Priority 2 looks to further integrate and provide consent for information sharing and the coordination of services to make them as accessible as possible, to build trust and improve family engagement. Priority 3, which speaks to expanding and integrating community-based approaches for youth care and intensive case management, including mobile crisis response services. These are organizations like MESA offering the wraparound services. Renfrew County Youth Wellness Hub is involved here, as well as Pembroke Regional Hospital's mental health services for Renfrew County. The 4th priority, which speaks to identifying and reducing barriers to access mental health and substance use health treatment and services, is really about providing opportunities to increase screening rates and support in the area of providing access to local resources. And finally, their 5th priority of decreasing stigma with training for healthcare partners and embedding peer support is just one example of a broader community-based strategy that we hope to use to reduce stigma. And it can be, recognized prevention programs similar to the Icelandic model. But to me, that's a model where it encourages equitable access to after-school programs and extracurriculars. And it also recognizes the importance of intensive early childhood and family supports through things like nurse-family partnership. Dr. Morgenstern mentioned earlier that at the same time the strategy is being developed, there's been some significant advances locally as implementation was occurring in parallel with the strategy's development. A few of those examples would be already enhanced and coordinated mental health and addiction support for youth in our schools through partnerships with Addiction Treatment Services, ATS, the Phoenix Center, RCDHU, and Algonquins of Pikwakanagan. A second example would be the Strengthening Families for Children and Youth program, which is a family-based program that RCDHU leads in cooperation and partnership with the Youth Wellness Hub, is set to launch next week. And recognizing that, as Patty said, the Youth Wellness Hub is a key resource for youth in our community, and we know that their membership or attendance has doubled each year since it's opened in 2021. Moving along to the treatment pillar, again, 5 priorities in this area, one being to increase and expand existing high-demand outpatient services that is currently exceeding service capacity. Secondly, to explore the possibility of establishing medical withdrawal management and stabilization beds in Renfrew County. Third, increase short and long-term housing, including availability and breadth of integrated services and specific services for people who use opioids. 4, continue to identify and reduce barriers to access mental health and substance use health treatment and services. And finally, to decrease stigma and training and support for healthcare providers in addiction treatment, trauma-informed and culturally safe practices by expanding, embedding peer support throughout the continuum of services. Now, I'm sure many of you who are aware through the County of Renfrew that there's been major advances in this area over the past year, and we must credit the incredible work of the MESA initiative that has gone a long way to providing mobile services that offer harm reduction and medical and social supports to people who use substances in Renfrew County and District. This will only be further enhanced through the successful Health Canada Substance Use and Addictions Program grant funding that will allow them to expand their mobile services to reach even more Renfrew County and District residents. We've also seen an enhanced level of access and support in transitional housing. This is through not only the Warming Center, but the partnerships the county has created with motels for those short-term and transitional beds. Finally, the recent success of the Heart Hub proposal which is led by the County of Renfrew and the Pembroke Regional Hospital, will align almost seamlessly with the treatment priorities identified here. Early work by MESA and the drug strategy partners, in particular the treatment working group, has put us in a great position for a strong and well-coordinated response under the treatment pillar. The third pillar, harm reduction, has 6 priorities. First, to implement remote spotting services. So spotting services is something that keeps an eye on, if you will, a person who uses drugs. Currently, we're promoting a phone line called National Overdose Response Service, or NORS, where a volunteer will sit via phone with the person while they use drugs to ensure that they don't become unresponsive. And just this week, we were in touch with NORS as they're working on the development of a mobile app, which would trigger a response plan individualized to the person should they become unresponsive. So we continue to monitor that as well. Drug checking, as you likely know, our CDHU launched a test strip pilot program last July, and as of early this year have provided 464 drug testing kits that people can use to test for the contaminants of xylazine, benzodiazepines, and fentanyl in their local drug supply. We're also working with County of Renfrew paramedics as well as the Toronto Drug Tracking Service to bring mass spec testing to Renfrew County and District, and are currently at the phase of working through their exemption to the Canadian Drug and Substances Act, and must again credit the work of Renfrew County paramedics and their team in continuing to see this through. You are also likely aware that through our Renfrew County and District drug toxicity response plan, should there be an increasing trend in either emergency department visits or fatalities, we have issued drug toxicity alerts in the past, and we thank our partners in media and addiction treatment around the county, as well as those that share those alerts on social media. But our goal is to be able to automate and centralize those alerts so that people who use drugs will receive the alert immediately via text or voice on their cell phones. One of the key components, and I know here at our CDHU, and we're incredibly proud of our harm reduction staff for their work in the past, but especially in the last year, in doubling the number of partners we have in Renfrew County from 7 to 14 who are distributing naloxone on behalf of the Ontario Naloxone Program. And we've established a public health nurse outreach team last June that reaches hundreds of people to offer harm reduction programming, naloxone, and sexual health and bloodborne infection testing. They're truly reaching corners of the county that we haven't been able to before through food banks and outdoor festivals and libraries. It's been a remarkable success and something we plan to continue. And just to note that in 2024, the Ontario Naloxone Program distributed 4,500 kits, which was a 60% increase from 2023, which again is a testament to all of their hard work. The fifth priority is about an urgent public health needs site. And essentially this is us laying the groundwork in consultation with Health Canada so we can be as prepared as possible should there be a mass casualty overdose event like the one Belleville experienced just over a year ago. Essentially, we'd be able to stand up an observation site, if you will, for those that use drugs to ensure that there's no overdoses or fatalities related to overdose. And finally, as I mentioned around the drug alerts, is to maintain our drug toxicity response plan. It truly is a fundamental monitoring, surveillance, and information sharing mechanism that's invaluable to our local knowledge transfer as well as our local response. And the fourth pillar, community safety, has presented 4 priorities. First, to implement a comprehensive non-emergency complaint report mechanism. And this is to provide a clear way for residents to report non-emergencies, but also collect objective data about the many areas of concern that the steering committee has heard founded, unfounded or not, things like discarded needles in communities, issues with social order, were some of the areas identified as priorities to capture. So the City of Pembroke will be extending the use of their Access E11 service for residents to either report online or via phone. Again, non-emergency concerns in their community. Secondly, we hope to improve social order by ensuring that the services that are needed are available to support individuals. Some examples of this would be mobile outreach, the services that are being offered at the warming center, ensuring that there are accessible washrooms in our community, all while addressing stigma among our residents. We're also exploring the use of a peer-based model. I know this will be integrated with SUAP as well as the Heart Hub, but to further provide those role models in the community and provide peer-led support. Another initiative that's relatively new is neighborhood contracts or good neighbor policies. And this again is to support and reinforce societal norms. Fourthly, we want to continue to ensure the safe disposal of substance use supplies. And again, this is just to continue to increase options for those that need to dispose of supplies through proper disposal and training and safely addressing drug use supplies if and when they're found in the community. Fourthly, enforcement is, of course, an important part of a community safety pillar. And while we fully acknowledge its importance, we know it's not the key and only mean of addressing substance use. Our partners in law enforcement also use a health-focused approach through their mobile crisis response teams that pair a mental health worker with an officer. We're also looking to integrate data between the OPP and by law enforcement to better inform their actions and identify any trends in the community. One other key component of the strategy that I just wanted to highlight was a collaborative communications group with representatives from the health unit, Ottawa Valley Ontario Health Team, County of Renfrew, Pembroke Regional Hospital, Phoenix Center, Deep River and District Hospital in the City of Pembroke. It was identified at many working groups that there are a lot of really great things already happening in Renfrew County and District that people just don't know of or know how to connect with. So we want to tell those stories, not only of the services that are provided, but also those that have reached recovery in their struggles with addiction. That's actually the next campaign you'll see beginning later this week, are stories from those individuals. And we feel that that will help put a face to the issue as well and help to reduce stigma. This group also supported with our online community engagement survey. As Dr. Morgan said, over 180 responses. They're in charge of developing our media releases and social media campaigns, some of which have been around naloxone distribution and stigma already this year. And again, just as I close the presentation, must recognize the partnering organizations around the steering committee table. I truly believe that the success we've seen in the last year is a direct result of the expertise and commitment put forth by these organizations and the many others that are represented through our working groups. It's this type of collaboration that Dr. Moore spoke to when saying that the health sector alone cannot adequately address the opioid crisis. So just for your awareness, moving through next steps, that yes, the steering committee currently has the draft report for their review and approval by March 31st, so we can release publicly next week. We want to confirm our evaluation and ongoing monitoring plans for the evaluation component, and to ensure, we're seeing progress in the priority areas. And we want to continue to engage with our community members as we release the strategy with the support of our partners. And again, while I said we've been, in parallel seeing implementation during the development of the strategy, it's now the continued work of not only the steering committee, but the working groups to implement the other areas and priorities that are required to continue our response. And just encourage you that you can follow the full release of the strategy next week through the website, which is rcdhu.com/rcdds. Thank you very much.
Thank you, Brian. As you sort of rightly point out, there has been a tremendous change that we're seeing over the past, year and a half, 2 years, with the partnerships and the outcomes and the number of activities and resources for individuals living in Renfrew County and district. So that is amazing. Hang on, my screen just did something funny. Oh, there you go. Okay. I see Troy's hand up. Thank you, Troy.
Thank you, Chair, and thank you, Brian, for your report. I just wanted to say kudos to you, Dr. Morgenstern, and all those individuals that participated in the Drug Strategy Steering Committee. I do think that we're seeing a difference, and put my counselor hat on now in terms of the city of Pembroke, but we are seeing a difference in regards to behaviors. We're seeing those reductions. We're seeing getting feedback in regards to businesses downtown with less disruptions, and I think it's really, really working. The support that we receive from the county in regards to the establishment of the warming center, as well as the Heart Hub. There's lots of good things that are happening, and I think that following the recommendations in terms of the report, I think is going to go a long, long way. We still got a lot of work to do. We can't take our foot off the gas, but even just looking at some of the statistics when we're going through this exercise, we're still seeing a lot of OPP interactions with drug overdoses, maybe not going through the system because they're being resolved through the use of naloxone but not being reported. So we can't take our foot off the gas. We really need to kind of make sure that we're continuing to move forward, but I think we're in a much better position. And again, I just wanted to say thank you to Brian and Dr. Morgenstern for all the hard work, and also the leads in regards to the working groups. I think that a lot of work and a lot of thought has gone into this initiative, and I think it's really going to pay dividends for the safety of our communities and those that are impacted through the use of drug substances and illicit drug substances. So thank you so much. I think it's a great initiative, and kudos to everyone.
Thanks, Troy. And Peter?
Thank you. Yes, just to add to what Troy said to Brian and to Dr. Morgenstern and the harm reduction people and all of the staff that have been involved. This is a really nice document. I like it. It's an overused word, but it's simple, easy to read, and Brian's presentation filled it out enough to I think I feel comfortable going out and explaining it should I be called upon. Two questions. One is under prevention and treatment, was there any thought given to adding in public transit? And in Renfrew County, public transit is likely to mean a different thing than City of Ottawa. It may mean a hodgepodge or patchwork services where, Careforce, Sunshine Coach, and I'm sorry, I forgot what the new coach in Pembroke's called. And then Bolshire Valley and Whitewater, and I believe North Algonquin Wilberforce have their car rental borrowing service. And then you look at the services provided by Cancer and Merchant Dimes and the volunteer drivers. So I think we're going to end up with a patchwork service down the road. So was there any thought to putting that in as a go forward under prevention and treatment? Because I know that we have mobile visitation, we have apps, But I still think sometimes there's a need for face-to-face and to follow-up appointments that can't be delivered at home or in a small group setting or in the back of a car or truck. Like I grew up with rural social work, so I'm a big fan of meeting people on their home turf. But you still have to get them out to services sometimes. So is there any thought to the development and prioritization of a public transit system, knowing that it would be different than Ottawa Transit?
I can certainly start, and Dr. Morgenstern, if you want to add, but yes, Ward Nemo, that would be part of the equitable access to these services.
Okay.
And I'm sure you're well aware of the hub and spoke model as presented for the Heart Hub, and we'll unfortunately, I think, have to rely on somewhat of a patchwork system, but it's how well coordinated that patchwork can be. Let's sew it into a quilt, if you will, and connect all the dots so that everyone in Renfrew County and District can access the services that are needed. For example, a great response to that was when the Algonquins of Pikwakanagan declared their state of emergency. There was immediate access to, I believe, 2 new vans to transport some of their community members to OATC and other treatment services in Renfrew County. So that's the type of uprising of support we need in the transportation area here. There's no doubt about it.
Okay, thank you.
If I could just add, sorry, along with that non-urgent transportation system does include other agencies at the community support level, like the Eganville District Seniors, the Barry's Bay Home Support, Arnprior, Braeside, McNabb, Renfrew, etc. And a lot of trips are being organized to OATC. I noticed our transportation statistics skewed in recent years to more like younger individuals than say seniors, and that it was skewing to OATC trips. So there's a big potential to network with the community support agencies and maybe coordinate that transportation to maximize the opportunities that already exist in that transportation system, where you can double up your passengers, so to speak, so that instead of driving one person to wherever it is, maybe you can drive 2 or 3. Anyways, I'll stop there. But
no, thank you. I was
great point. Great point.
Sorry, I was quite clumsy in how I said it, but yeah, that's what I was trying to get to. And Brian, my name is Peter, thanks. And we've known each other a long time. And so the other piece was the under community. Was there any indication or thought of rehabbing what used to be known as a situational table as a means of ensuring that the various partners knew of somebody who was struggling or was still finding gaps in the system, so that they didn't end up overusing Emerge or getting to such a point with the OPP that ended up being a charge because they were just and I hate to use this word, but maybe considered a nuisance. So is there any thought of doing that? Because it was an informal case management tool in a lot of ways to make sure people got directed into the system. Again, an overused word, the system, but directed into the level of care that they needed. And then I'll stop. Thank you very much.
No, excellent point, Peter. That it was a key table to discuss those individuals that required kind of wraparound support. As part of the community safety situational assessment, we did bring in Pat Finnegan, who many of you who will remember from the community safety and well-being plans that were developed for our municipalities. And it's escaping me at the moment, but I thought that the situation table had transitioned under a different name. However, I would say that even in its absence around the community safety working group, we have our police representation, parole representation, bylaw representation, who are essentially discussing those very things. Not only community safety at a broader sense, but they've had some kind of sidebar conversations about particular members of our community or families that could require additional support. So duly noted, and I will look for the name to make sure that they are indeed still meeting in that capacity.
Great. Thank you very much.
Thank you. So I don't see any other, oh wait, one more, Jason.
Sorry, just really quick. I think from a treatment perspective too, actually, as part of MESA, a number of the service providers are having regular huddles and sort of, so perhaps not exactly the same thing, but I know that there is, an attempt to have that kind of coordination. And just on transportation quickly, I think the approach that the steering committee took was to try to embed it in a few of the different ones. So one that Brian mentioned was, our equity approach, but also the mobile services and enhancing those, to address transportation. But I just wanted to clarify as well that it was discussed multiple times, and I know that for the Heart Hub, it's going to be a key as well, consideration about transportation as a key barrier. And then the last thing I wanted to say that I didn't say in my opening with my report is just to acknowledge Brian's work. He's been really pivotal to the strategy. He's the coordinator of the drug strategy, and he's at every steering committee meeting, many, if not all of the working group meetings, and doing a lot of the behind the scenes work to lift this up along with a lot of our partners. But Brian has been really key and been doing excellent work. So I just wanted to thank him.
And
Thank you, Dr. Morgenstern. I'll
but-
just sign off by saying it's Renfrew County Community Risk Watch is what I'm seeing as replacing the situation table.
Good. Peter, you put your hand up again.
Yes, thank you. I just wanted to mention I'd heard really great things about Brian and wanted to make sure he got recognized. And then the last thing is that the County of Renfrew has stood up an ad hoc committee to take a look at if there's a means of coordinating all those disparate pieces of the formal and informal transportation system, loosely used word, that we have in place now to try and maximize both the value and the utility. So as we get more information, we'll pass it back to this group. Thank you.
Very good. So I'm going to keep us moving at this point. Carolyn had to leave as she had let us know ahead of time. We do still have quorum. I'm moving on to the board committee reports, and we will invite Troy to come forward on behalf of governance. Thanks, Troy.
Thanks, Chair. Short and sweet. I have the privilege of reporting in terms of the governance committee report that was, or the meeting that was held on Tuesday, March the 11th. And so what we did is we looked at reviewing and the revisions in terms of the procedural bylaw. And we continue to look at the bylaw for revisions, and it's actually going to be scheduled to the next meeting in terms of April the 22nd as well. And then we did look at the action list, but there was really no actions for the governance committee at that time. So that's it. Short and sweet.
So can I call for a motion, a mover and a seconder for a resolution on that report? Jim, seconded by James. Thank you very much. All in favor? Oh, wait, sorry, Jennifer, I see your hand up. I don't know if you have a question or if you were moving or seconding.
I was going to move or second, but that's okay, Chair. Now I'm sitting.
Okay, so that was carried then. I just wanted to make sure I didn't miss a question from you. So that we had the mover, the seconder, and it carried. Thank you. And resources. So now, Mike DeManoir, please.
Thank you, Chair. I'm pleased to report for the Resources Committee, which met on March the 18th, last Tuesday. For information, we did review the Q4 financial report, and which would be for the end of the year. Notice that there was a slight overspend in the year as a result of a couple of specific programs, and it is expected that the ministry will approve additional funding to cover those off. In both cases, they're ministry priority items. And now that the election's over, the staff are expecting that approval to come fairly soon. As far as the action list, there were no items on the action list that were directed to the committee. We do have one resolution or one recommendation with respect to the draft budget and service plan that was presented. The committee reviewed the budget, the highlights that were noted are in the report. I'm not going to repeat them. But in general, they were in line with the same numbers that we were presented with in December when we were looking at the municipal levies. I think that's my report. Thank you.
All right, thank you. And I'm just, there we go. So I can see, okay, I have a hand up from Peter.
Yeah, sorry, I know people are going to hate my voice by the end of the meeting, nearly as much as I do. So the question I have is, the report tells us that the ministry was 72% or whatever, and the municipalities was 27%. So that if the municipalities were to hold fast and say, no, we're only going to spend 25% instead of 27, what kind of gap would that leave in terms of dollars? And then secondly, is that gap, would that gap have been met had there been a reasonable cost of living allowance instead of a 1%? Long question, not likely to be answered today.
Well, I think we did discuss some elements of what would answer that question, but I would probably defer to Heather to actually, I mean, especially on the percentage of if we'd had a reasonable cost of living increase that was more commensurate with what we actually needed in terms of the other factors and human resource factors and all. I think we would have been in a better position for sure. We also would have been in a better position if we had voluntarily merged. But that's another question. I don't know, Heather, if you want to add anything to that.
Yeah, I don't have the calculations right in front of me, but I can get those for you, Peter, for sure. And yeah, and we can look at that. But we definitely would have been in better shape if the ministry had given more than 1%. That's absolutely for sure.
But point of order, Chair, you can't necessarily say that we would be in a better position if we had merged.
Well,
we don't know that for certain.
Except for what we're seeing from other health units and what we're hearing at Alpha.
Just the funding piece, I think.
We might not have been in a better position overall, depending on how you qualify what's better and what's good. So you're right about that.
I just think it's a dangerous statement. It's a dangerous statement to make to a board that voted not to merge. And so
financially, the question though, financially, the financial situation would have been much different. That's all. And that's what we're seeing as a fact in terms of the comparison to other health units and what the ministry said. So you're correct. I stand corrected on qualifying that overall as better. I should have limited my comment to financial. Thank you. Neil?
Thanks, Chair. Just a question of what I saw. One point I saw in Michael's report, it spoke to the over expenditures or the over programming, however it was worded, on the seniors dental program. And personally, I'm good with taking a little bit of risk and leaning forward in terms of providing that support. I'm just wondering how that was assessed. Was the over programming deliberate? Did we know we had more funding in the pipeline, so we leaned forward a bit? I just want to learn more from it so that we can continue to lean forward in the future.
I'll try to answer that one, Neil. The ministry did indicate mid-year, again, if there are pressures, that would be mid-year of 2024, when there are pressures in the program with demand, and they mandate they don't want waiting lists and people put on hold. So they have been following through, and we have been requesting additional funds for several years to make sure we are addressing those waiting lists for our people in our community. And the ministry has held true to that. So they've been delayed, but we anticipate no issues.
Very good. So are there any other questions? Let's see. I saw Troy and then James.
I did a thumbs up instead of my hand up, but
that was a thumbs up. I misread it. Pardon me.
That's all right. But I do have a question, and it's in regards to maybe as a result of the recent elections in terms of provincial elections, and then we have Billy Deneau as our MPP. I'm just wondering, what is the process or what is the status, or how have we given any thought in terms of giving Billy an update in regards to our current financial status and our concerns as a health unit? Just because I know after speaking to Mr. Yakubuski, there is no transition in regards to information. It's like start from scratch. So all the information that we provided John and for John's awareness is no longer exists as a result of the transition. So I'm just wondering what are we looking at in terms of providing an update to our rep in regards to our current status?
Chair, if I might, I was, when we got to the end of the meeting, was going to make a suggestion. I had reached out to him about a number of things prior to the election and during the election. And one of the documents I gave him was the election readiness thing. I believe was Heather produced for us. I worked it around a little bit and took it off the letterhead because I think that was the request, was to not be overly specific. So we had a meeting about that. I sent him an email just recently about 5 topics to have a meeting with, and that was one of them, was the health unit funding. The other piece was I have sent a letter to Minister Jones asking for a meeting via the municipal sector, concerned about the 1% and what it's doing to us, and was going to bring that up at the end of the meeting, just to ask for the board to recognize it as an effort from the municipal sector, and offer the opportunity for the chair and the medical officer of health to attend if they were able to, as soon as we got the meeting. So we were taking, the members of county council had spoken about it. Neil, James, Jennifer, myself, and one other person, about making sure we were out the door as fast as we could with some of these issues. So weren't trying to shut out the board, but we're looking at it from the impact on the municipalities. Thank you. So if that, if the board's in agreement with the medical officer of health and the chair attending, should we get a meeting with the minister, then, and I don't think, in the future, they really need to get permission. I think that's part of their mandate is to be out there. But I think as we move forward, and mature as a board, maybe this is an opportunity to reaffirm that. Thank you.
Yeah, I had it down as a question under the action list if the board wanted to direct the chair to take some action in that regard. So that's interesting that you've already, kind of like undertaking some action in that regard. So we're still on the resource committee report. And James, thank you, James. Yes, thank you for reminding me you were on the speakers list next.
Thank you, Chair. And really more just a suggestion. Going forward, it would be really, I think, simpler and helpful if the actual draft budget was included on the agenda. I know the link was there that you could go, but I think going forward, it would be really nice if the budget and then the justification report was all attached under the agenda. Thank you.
So that's another great suggestion for the staff to look at how to, if that works. And in the meantime, I think we're back now to the motion, the resolution to approve. We have a motion on the floor. I think that the chair of the resource committee has made the motion through the report. And so I'm looking for a seconder, if I'm correct, on point of order. Peter is seconding. Sorry, Neil, I saw you guys tied. All in favor? And that's carried. Thank you. Correspondence. Now, I didn't print out the correspondence this time. My I have to put a new thing of toner in my printer. I was running low. So I'm gonna ask for some help going through the correspondence, please. From maybe Heather and Jason.
Would you like me to put it up on the screen? It's the Alpha, the info break. March.
Chair, you're on mute.
Sorry, thanks, Jennifer. I didn't realize I'd muted again. I was just talking about the info break. And at the end of the info break where they have the board resources, there's a live link that you can go and watch a video workshop on legal issues and matters for boards of health. There's a couple of really great links in there. And although that legal workshop did have a bit of a focus on COVID, it also had a lot of other, and from what I can tell, still accurate or valid. There was one question I wrote down that I'm going to follow up with later with Melissa and Heather about something from 2021 that I wanted to find out if that was still the case that they had said at the time, because they made some changes to the HPPA a little bit to allow for virtual meetings and things. But anyways, I found that really interesting personally. It's the Legal Matters Updates for Boards of Health video, June 8th, 21. And then the Obligations of a Board of Health under the Municipal Act revised in 2021. So I found both of those to be really interesting, and I want to follow up later on a few points that I had questions about. So anyways, that was my, did anyone else have anything they wanted to say about the Alpha Info Break? Jason, sorry, thank you.
No problem. Just wanted to mention that Dr. Malcolm Locks noted in there, and he sadly passed away recently, but while he was actually in his duties as the Grand Erie Public Health Medical Officer of Health, and he was very actively engaged with responding to the measles outbreak while this happened. And I've actually had the opportunity to work with Dr. Locke over the pandemic as well, and he's a great public health physician and had been serving that area for decades, and actually retired formally about 5 years ago, but kept coming back to help out. So anyway, just wanted to note that in there.
And I'm just looking to see if there are any other comments or questions on the correspondence. Moving on then, we have no procedural bylaws coming forward this time. We have no new business coming forward at this time that had been put on the agenda earlier. Action list review is where we're now at. And so the point 1 and point 2 and 3 in a sense, although point 3 we're hoping that these are all sort of board delegation or education or information sharing actions. And one of them we're hoping will happen at the in-person June meeting, at which what I hope will happen is the in-person board meeting will be followed by a meet and greet with the staff, as we did last year, and I found that to be very helpful, and I think it was a good use of our time. And then hopefully the other action items about partner information sharing or resource collaboration. Partnership came up today, I don't know how many times. Key priority. Everybody knows it. We want to keep doing it. We already are doing it, but still it's a key component, tactic, if you will, strategy in going forward with our public health accomplishments. And so on that note, with the board retreat planning, there's been some early brainstorming, although it's still pretty loose, a little bit loose, is to have the board retreat take place in lieu of our October board meeting. And I'm hoping that the stakeholder committee will call a meeting in the next month or so to do some brainstorming, to kind of finalize the theme for the day, finalize the location. Maybe some of our stakeholder committee municipal people will have free space for us to have it in, or maybe we'll have it at the health unit. I don't know. These are things the committee could discuss and see what would be the relative merits of options and come up with a good solution. And then the partners and the topics that we wanted, the theme, if the theme was going to be something along the lines of partnering or collaborating with community partners to achieve public health goals or something along, maybe that's too many words, but something in that neighborhood, then that's where the stakeholder committee would, I think, have an important role to play in helping us to determine the key themes and partners and collaborative efforts to highlight. And I think it would give us a good place to do some more kind of forward visioning as a board, even though our strat plan is still valid for another whole year. As things emerge, it's always good to kind of rethink a little bit where what's our long-term vision, where are we going, what do we need to do next to keep that continuous quality improvement that we are already seeing, continuous quality improvement 100%. And although I want to always celebrate that, I don't want to necessarily be satisfied to leave it at that. So it's a kind of a balance between, you know, celebrating the success and then, okay, what's next kind of thing. Anyways, all of that was kind of long-winded, but that was is there anything else on the action plan that I missed mentioning, you guys? Or action list? I see Troy and then Neil. Troy?
I'm just thinking in terms of an addition, could we add the action in regards to their political engagement between the chair and you know, the representatives for the county or municipal representatives?
Sure, because it might or might not work out to do it with the county. We might need to do it on our own if timing was such or whatever, and that's probably perfectly legitimate way to do things. Someone else had their hand up. Neil. Oh, and then Jennifer.
Same as Troy. I was
Same thing as Troy. Okay. And Jennifer?
Yeah, the warden seems to have vacated his seat there. He's just the County of Renfrew logo now. What I was going to say was that since the warden has already initiated a meeting with Billy, and we've had many discussions about many different issues, I would say that it would be most appropriate for the county and the there's Peter back. The county and the elected and chair, if you wanted to join, then that's fine. But I think it would be more appropriate for the County of Renfrew to meet with him and maybe with Ethel and Troy, only because we've initiated, or the warden has initiated, and I've had many discussions with Billy as well. I think it would be more appropriate for us to meet with him first, and then you come in as backup if something goes sideways. But I don't know what the warden thinks.
And the bylaws do call for to be communicating about the health unit to anyone at a higher level, I think should involve the health unit in some way, Jennifer.
Absolutely. I'm not saying that.
Yeah.
What I'm saying is, since we've already initiated, perhaps it should be a county meeting with other stakeholders.
Did you say something there, Mike? Or no? And I see Carolyn's back. That's great. Anyways, I probably want to think about that a little bit in terms of the process of making sure that the health unit's needs are distinct, although they are obviously connected to and within the realm of the overall county and municipal concerns. The municipal concerns there may be many other matters, whereas for the health unit, we're talking about public health matters. And so I see the connection at the same time. So Neil?
Yeah, I'd agree, Joanne. I think the municipals got the issue with the finances as a number one priority. And that may be an excellent opportunity for the health unit to be a participating agency amongst others in that briefing in order to advocate for the funding side of it. But I think we still need to make sure that the health unit itself can approach the MPP and speak about health unit things that really the county is on the peripheral of anything.
Yeah, thanks. You said that better than I did. So I think, so should I just ask by show of hands, is there agreement to add something to the action list that wants the chair and senior management to also communicate with the new MPP on public health matters? If you want, you can combine it with, you know, be a partner with the county and others, the city and South Algonquin, and also take responsibility to initiate public health conversation.
If I
Peter?
might, Chair, I
Okay.
agree with that because I think it's more has more of an impact with likely with the MPP, but also likely with the minister, that the presentation to them talks about, first of all, the money, and then secondly about public health concerns. And I would suggest to you that probably the new standards, which haven't been released yet, is of concern, and other areas as well. I can't remember off the top of my head, but so I think that it makes more sense than us setting up a meeting from the municipal side, hinting there might be more, and then 6 weeks later or whatever, then, you know, the senior management makes it a meeting with the minister and tries to connect the dots. So, you know, I think a unified approach is much better than a scattered one, and that's why I made the request for the meeting and then brought it to the board. I didn't do anything behind anybody's back. So I think, you know, I think you're right. I think it's better to go with two briefs, one on the finance side, and then secondly turn to the issues that the health unit have about whatever the structural settings are, and we would nod in agreement. So you know, just in short. So thank you.
Okay, and I do see Carolyn's hand, but just before that, I thought I saw some hands in the screen, but not the little yellow hand. So I don't know if I'm missing somebody, but if there was someone before Carolyn. James?
Thank you, Chair, and I agree in the partnership approach as opposed to individual approaches. I think it's more effective and more efficient use of time as well. Thank you.
And Carolyn?
Unfortunately, I missed most of this conversation, but what my suggestion would be is any meetings or whatever with our new MPP would include, certainly if we feel it's right, people that work for the health unit, but definitely if the chair, and I would suggest a municipal member and a public member, not just the chair. I'm sorry, but that didn't work last time. It caused a lot of issues, a lot of talking among us, and you need to have more board members going to that meeting. So my suggestion would be a municipal one and a public one, along with the chair and whoever from the health unit. Thank you.
So it seems like there's agreement to add those action items to collaborate with the county in their meeting, and to also initiate subsequently a meeting on public health matters. And your words are duly noted, Carolyn. On that last meeting, that number of people at the meeting was determined by John's office. So that may be a factor. We may be trying for something that the MPP may or may not agree to, but we'll definitely keep your comments and suggestions in mind. I agree with you that it's beneficial to have a few other folks around the table. Is there anything else that I missed on the action list review? Heather, Jason, anything else that you're noticing? Anybody else? No? That means we don't have any notices of motion for the next meeting to my knowledge. We have no closed meeting. That brings us then, I'm looking at everybody to make sure this is still okay, that we're looking at the next meeting of April the 29th at 10 a.m.
Chair, can I just make a suggestion? I know that primarily we're doing Zoom meetings, and if it's workable for everybody else, could we start at 9 o'clock as opposed to 10? It just gives us more of an opportunity to get lunch and sometimes follow up with our appointments in the afternoon. And if we could start at 9, that would certainly work out better, at least for me. I can't speak for everybody, but
No,
certainly for me.
That's funny. I would like that too. Who else? Maybe we'll come back to that in just a second. Let's hear from Neil first, in case it's a similar point.
No, it's fine. 9 o'clock is good, is a good start time for me as well. Chair, I just wanted to put a placeholder on a date, only because you're talking about the next meeting and it'll be pretty close, but May 15th, if people want to hold that, we're talking about an age and place conference being hosted in, and maybe you could speak to it more, you might know more about it than I do. But just to make sure that's on our date from a public health perspective.
Yes, the Aging in Place Forum, as far as I know, will be May 15th at the Clarion Hotel, I believe, in Pembroke. I think they have a futurist coming, and I forget who all exactly. It's the Ottawa Valley Ontario Health Team organizing that. So back to James's suggestion, which was specifically towards the next meeting date of April the 29th, and a suggestion that the meetings start at 9. And I do see your hand up, Carolyn.
All I was going to say is, since day one, our meetings have always started at 10. It makes it a lot easier for the people driving and that kind of thing. And 9 will really suck for me, because but I mean, if we vote on it and that's how it ends up, fine. But it has always been 10, since that's how it was in our bylaws from day one. So.
And Mike DeManoir, yeah.
Yeah, I just wanted to comment that historically they started at 10, as Carolyn said, because of people having to travel. But that's not the case if we're meeting online. So I'm good with a 9 o'clock start.
I think the bylaws say, usually the bylaw does state 10 a.m. as the regular starting time, or at the will of the board or something like that. Like, there is an option in there to change that in the wording.
In our last discussion, I'm sorry, we talked about going back in, if you will recall, and that's going to start again. And it comes first in our bylaws of being at the Board of Health being at the health unit for our meetings. So, you know, I don't think we can just change things without changing bylaws. And if we're not jumping into that right away, I have an issue with it.
The bylaws do allow for a change of date and time already at the will of the board. So that's one thing. The discussion that's happening about meeting in person, I totally agree with you. That's conversations happening at governance, and very well may be that that the group may agree, that group may decide to bring back that recommendation to go back to in-person meetings at the health unit. I don't know where we're going to end up. We had the conversation. Troy, jump in. We didn't really decide yet. I think we had the conversation, and then it would come back to the board, and then the board would ultimately decide. And I know other research will be taking place in terms of what's going on in the rest of the province. What are health units doing in today's world around meetings and so on and so forth. So there, a lot of that's still up in the air. So if we were to, I see you, James. So if it turned out that the majority wanted to go to a 9 o'clock start next month to try it out, and then if later we go back to in person and we need that time for travel, well, we'll just be like changing our minds. I don't know. I'm just James.
Yeah.
Thank you, Chair. And I don't disagree with Carolyn that if it's in person, I can certainly agree with the 10 o'clock. And maybe the bylaw change would just have to be that when we're doing Zoom, we do 9. When we're doing in person, it's 10. It's just another way of looking at it.
And Mike, yeah, thanks. Troy cut the piece out of the bylaw for us and put it into the chat. Thank you, Troy. And Mike?
Yeah, I was going to suggest that we just leave well enough alone and let governance deal with it at this point.
Exactly.
And it's the will of the board. It's really about the will of the board. So we have a couple of suggestions we could do, you know, anyways. Maybe it's, and I do hear what James is saying though, that when we don't finish till afternoon, after 12, we don't get our lunch. If you've got afternoon meetings or appointments and you need to travel for those, it's cutting short. Sometimes people have to leave early because they have afternoon appointments. So it's hard to find a perfect solution is the other truth of the matter. How many people, we know Carolyn for sure would not like a 9 o'clock start. Is there anyone else who would find a 9 o'clock start impossible or really difficult, just by show of hands? Anyone else hates a 9 o'clock start? Okay, nobody else hates a 9 o'clock start. Would anybody who prefers a 9 o'clock start? 1, 2, 3, 4, 5, 6. So, I mean, the majority seem to prefer an earlier start. I know that the bylaw says it's 10 o'clock. I do believe the board is allowed to change that. What about staff? Would that have an impact on you folks one way or another? Do you need more time to get ready for a board meeting, or would 9 o'clock be a problem? Because it's in my mind to say, what if we tried it once to see what happens? But I don't know. Or we leave it till the governance committee finishes its review. Those are kind of the two options on the floor. I know Carolyn would prefer we leave it. Mike DeManoir suggested we leave it. Anybody else have a strong feeling? What if we just leave it?
Please. I
feel like this is somewhat indeterminate in my mind. We're approximately split. Approximately half of us would prefer an earlier start, but probably not if it was in person. Let's just leave it the way it is for the moment and maybe continue to look at this in honor of the request to free up afternoon time for people and to finish before lunch. Because I think that's another valid point to look at all the needs of all of us. Yes, Carolyn?
The way this was always done is we started at 10. We went till about 11:45. We had a nice lunch, and then we continued our board meeting. That's how it was always done since Mike and I started in around 2012, 13, 13 maybe. It's just, I don't understand these changes, and I don't feel good with changes being made without it coming to governance and the bylaws being made. Like, sure, if like when we were at our meeting last week, we talked about having in-person meetings. Well, we didn't just change that automatically. We said it has to go to the board and be talked about and as a bylaw change. I think this would have to be a bylaw change. And so that's my issue. Yeah.
Fair enough. And as I was just actually saying, I was actually just saying, Carolyn, that I thought we should leave it for the moment. So you're echoing in on that again.
Yeah.
That's good. I feel that you're supporting that. And I'm also acknowledging that half of the board members would like an earlier start if it's not in person, just to further their own personal needs. And I think that's also reasonable that we look at. I understand what you're saying about the past. Since I've been on the board, which is now, what, 4 years, that hasn't been like that. So I have no experience of that. And I look around the table and I think probably the majority of the board members were not around. I mean, there are some who were. I have a feeling the majority were not. So we're not really, we didn't have that lived experience, the history experience that you have. So anyways, governance committee does have this on their action list to be considering. And it's good that we're having an initial conversation about it, because then the rest of you will know that the bylaw committee is looking at should meetings be planned to be in person, and except perhaps in the bad weather of the winter or something. But anyway, so we are looking at that, and we will be looking at that. And you may be, in all likelihood, you're going to get asked to decide on that when the bylaws come back. And Troy, I don't know, do you think that's probably going to be, by the time we get that all done, it's probably going to be the August or September board meeting is my hunch, just because of other deadlines and things coming up?
Yeah, that would be correct.
Yeah. All right, so we've got the date and time of the next meeting, and I think we could call for adjournment if that's okay. Troy moving to adjourn, seconded by sorry, Peter, you and James kind of came up at the same time. All in favor? And that is passed. Thank you all very, very much. That was great discussion. Jennifer, do you have to run or could you stay on and or
No,
you-
sorry, I have to eat and I have another meeting in about
Okay.
20 minutes.
can I leave it with you and Melissa? Could Melissa follow up with you to see about a date and then maybe
Yes.
let me know and ask me if you have any questions?
Absolutely. I'll make that happen.
Thank you.
Melissa, don't let me forget.
Take care, everyone.
Bye,
Goodbye.
everybody. Thanks.
Bye.
Great meeting. And now, should I leave the meeting now? I just realized my